So I wanted to thank Lenny for inviting me to speak today, and I'm going to talk about the treatment of ALL in young adults and adolescents. So there have been several retrospective trials that have demonstrated a superior outcome when adolescents and young adults are treated with pediatric-inspired therapeutic regimens. And so this slide shows data from two trials that were published, one by Wendy Stock and one by Nicholas Boiselle. So Wendy's data was from comparing the CALGB adult group data and the CCG pediatric data, and Nicholas Boiselle's was from the French pediatric and adult cooperative groups, respectively. And you can see here one of the biggest things that came out of these two retrospective trials was that the outcomes were clearly superior for these adolescents and young adults treated on the pediatric trial regimens. And so the event-free survival was 60 to 70%, versus only about 30 to 40% in the adult cooperative groups. And so this was really, I think, very important and really led to a lot of discussion. And in addition to these trials, actually, this data has been now replicated by many other groups in different countries. And so the question is, why are these outcomes different, and what are the differences in the regimens? And so there was a very nice meta-analysis that was published by Ram in the American Journal of Hematology that summarized actually 11 of these studies and about 2,500 patients, really focusing on this specific age group. And in this trial, in this study, they actually show that probably the biggest differences were the doses of incristin, the doses of steroids, asparaginase, and also of intrathecal therapy, so of intrathecal methotrexate. And this is actually very different than in the adult regimens, where we tend to actually use more of the myelosuppressive agents. Here, in most of the pediatric regimens, really there was more focus on some of these non-myelosuppressive agents. And so, kind of summarizing the data from these retrospective studies, it seems that dose intensity and drug selection probably are very important in terms of outcomes. The other thing is, looking at the CALGB and CCG data, earlier and more intensified CNS therapy in the pediatric regimens actually decreases the risk of CNS relapse. And so in Wendy Stock's paper, that risk was about 11% in the CALGB trial versus about 1% at 7 years in CCG. So quite a big difference there. And then the last thing is that in the pediatric trials, there has been typically a prolonged maintenance phase. And so these are kind of the key differences in terms of therapy that may account for some of the differences in clinical outcome. And so this data is what led to the development of CIA 10403, which was a clinical trial for adolescents and young adults with untreated ALL. So this was a large prospective study to really evaluate the feasibility of utilizing a pediatric regimen in adolescents and young adults treated by adult hematologist oncologists, because one of the other questions has been, does the treating physician matter? Does it matter whether these patients are brought by their parents or they come on their own? And so this study also sought to address some of those other psychosocial factors. And so in this trial, patients were included between 16 and 39 years of age. Now, one thing to note, which I know was brought up yesterday, which I think is important in terms of analyzing the results, is although the age limit went up to 39, that change actually happened later in the protocol. And so that may account for one of the reasons that the patients, if you look at the patient subgroup, which I'll show in a little bit, the patients, there are fewer patients in that kind of older patient age group, which some of it may be due to physicians, but I think some of it may just have to do with the logistical implementation of this trial and the fact that that was included later. And so in this trial, really, the main outcome was to really look at clinical outcomes, so to look at event-free and overall survival. But embedded in this trial, there were actually evaluation of molecular genetics, minimal residual disease. There was a nice analysis of psychosocial factors, which one of the fellows working with Wendy Stock presented at ASH a year or two ago and did a very nice job with that. There was toxicity data, which we'll talk about today. And then the last thing is really looking at treatment adherence, both by the patient and also by the physicians. And so in terms of the background for the C10403, as part of this trial, we actually took one arm of the CALGB arm. So I'm just going to briefly talk about the 4 arms of the CALGB trial, and then I'll discuss what we used in our particular trial. And so for the CALGB trial, there actually were 4 arms in this trial. And this trial was really based on the fact that despite significant improvements in outcomes in pediatric ALL, there really has been a shift more from systemic failures to CNS failures. And so the COG trial really focused on 2 major questions. One was looking at dexamethasone versus prednisone. Since dexamethasone has the potential to decrease CNS relapse by 50% in standard risk patients. This has been shown in CCG 1922. And then the second part of this trial was also to look at high-dose methotrexate versus Capezi, or basically dose escalation of methotrexate. Again, looking to see whether this would improve CNS control. And so this is a slide that was provided to me by Nita Seibel, basically just summarizing those 4 arms. So again, there were 2 randomizations, one for prednisone versus dexamethasone, one for Capezi versus high-dose methotrexate. And all those randomizations were done at the time of study entry. And so the P is the prednisone, D is dexamethasone, H is for high-dose methotrexate, and then the C is the Capezi methotrexate. And so in our particular trial for C10403, there was a lot of discussion. Optimally, you would have wanted to have the 4 arms and replicate that trial, but given the number of patients, given the fact that this was going to be quite a change for adults treating with a different regimen, and the logistics of accrual, we decided to focus on just one arm of this study. And so initially, actually, we had chosen the DC arm with dexamethasone, but right as we were getting ready to open the study, we received the data from the CCG trial showing that there was an increased risk of avascular necrosis in the older children. And so because of that, the trial was then subsequently amended to the PC arm. And the second thing I'll mention is that there was a lot of discussion about minimal residual disease. So although minimal residual disease was measured in our trial, that data was actually not actionable. So there was no difference in terms of treatment for that. And that data was not necessarily available in real time. So those were some of the main differences. So today I'm going to talk about the toxicity data from that trial, but just as some background in terms of toxicity in this population, as patients age, there are differences in both organ function and also potential differences in terms of metabolism of drugs. And so in the CCG studies, there has been shown to be an increased induction mortality in adolescents when this has been compared to younger patients. And there are some specific complications typically related to both asparaginase and steroids, including diabetes, pancreatitis, and also avascular necrosis that we seem to see as patients age. And so this first slide actually shows some data published by both Jim Nachman as well as Dr. Berry. Looking at these age groups, again, this is focusing on kind of a younger population between 1 and 21 years of age. And you can see that in the very youngest age group, the 1 to 10 years of age, there's actually a very low incidence of thromboembolic complications, pancreatitis, encephalopathy, and hyperglycemia. And you can see that the complications do increase with age. But interestingly, not all these complications are actually higher in the highest age group. So for example, if you look at thromboembolic complications in their trial, actually the 10 to 15-year-old age group had a higher incidence than the 15 to 21. The main one that does stand out is hyperglycemia, so that was clearly age-related. But for some of these other complications, they don't necessarily increase along the age spectrum. Now, avascular necrosis does have a higher incidence as patients age. So if you even look at patients greater than 10 years of age versus the very youngest children, 1 to 9 years of age, in any of the trials that have been published, you can see that there's a higher incidence in that age group. So in the CALGB 0232 study, that incidence was about 15% in patients greater than 10 years of age versus only about 3% in children. And again, if you look at the CCG trial, that incidence also seems to really go up with age. So in addition to the toxicities we've mentioned, one of the other things has been the hematologic toxicity. So Ribera et al. Looked at this in their particular study and did show, looking at even young adults versus adolescents, there was a higher incidence of grade 4 neutropenia, grade 4 thrombocytopenia, a higher risk of infections, and a higher need to dose modify either vincristine or asparaginase in subsequent cycles. And so this was a concern as we were designing this trial and people were enrolling patients. I think one of the biggest questions that came up is, can this be done safely, and what is going to be the toxicity? And so this trial accrued between 2007 and 2012. There were 318 patients in the U.S. that were enrolled by the 3 cooperative groups, CALGB, which is now the Alliance, ECOG, and SWOG. In this trial, the majority of patients were Caucasian, although about 26% were either African American or Hispanic. The majority of patients, so about 58%, were in the 20 to 29 years of age group. So again, only about 28% were in this older age group, 30 to 39 years of age. So that's important to note because that potentially may affect some of our results here. So the first thing we looked at was really looking at the induction toxicity, grade 3 through 5 adverse events. And in this trial, basically in the poster that we presented at ASH last year, we really were trying to compare our results on our trial with the PC arm of the COG trial in patients that were greater than or equal to 16 years of age. And it's important to note that the majority of those patients were in that 16 to 20-year age range, so kind of a younger age population. But that was kind of the best comparison that we could come up with. And so there was a higher incidence of hyperglycemia by a little bit, so 29% versus 22%. There was a higher incidence of bilirubin, which I think most people would expect, and I think we talked about that a little bit yesterday. And there was a higher incidence of febrile neutropenia during induction. But if you look at the incidence of thrombosis, maybe slightly higher, pancreatitis, again, maybe slightly higher, an allergic reaction during induction. We'll talk a little bit about during the subsequent cycles was different, but during induction there was no significant difference. And so then the question is, how about the adverse events throughout the course of treatment? So I know this is a very, very busy slide and maybe kind of a little hard to read, but I wanted to be able to kind of show everything here. So the main thing to focus is really on the lines that are bolded with the star. Those are really where the differences were. So I'll just kind of go through each of these. So the first thing was the risk of allergic reactions. You can see that the incidence was actually higher in the COG trial, but this was during subsequent courses. And early on in the C10403 trial, we actually incorporated pre-medication into subsequent courses. And so that likely explains why there's that difference there. There was a lot of debate whether that, we may be hiding silent hypersensitivity reactions, but because there was a fairly high incidence early on, we had amended the trial. The second thing was there was a higher incidence. If you looked at coagulopathy, there was a higher incidence of patients with low fibrinogen levels. Again, those typically are not treated. They're not necessarily clinically significant. In the subsequent courses, there was a higher risk of thrombosis, so this was about 7.6% versus 3.8%. Interestingly, and I guess I was actually surprised, there was not a significantly higher incidence of transaminitis or hyperbilirubinemia with subsequent courses. So I actually was a little bit surprised with that. In terms of the risk of bone complications, again, the risk was not significantly higher. I will say that the study is still early on, and so I think we have to kind of keep that in mind and follow up for these patients. And again, the other part is just the reporting of these and how careful people are monitoring them. And then the last two things, actually, which were kind of interesting, is they're actually, in looking at the COG-0232 trial, there was actually a higher incidence of motor neuropathy and a slightly higher incidence of encephalopathy. So I think the biggest thing to take home from this is really that I think we were actually surprised that the toxicity was fairly manageable in this population. Again, you have to still keep in mind that about 60% of the patients were in that 20 to 29 year age range. And so that may affect some of these results, but this was quite promising. And so the other part is the clinical data. So we actually do now have the clinical data back from this trial, and Wendy Stock will be presenting this at ASH, and it's been accepted as an oral presentation. So we're very excited about that. And so really, I think these data indicate that treatment with a pediatric regimen is feasible when administered by adult hematologist oncologists to an AYA population up to 40 years of age. Again, it would be nice to really have a larger sample size for those older patients. And really the hope is that this regimen can be used as a foundation for the design of successor trials in this patient population. And the clinical outcomes and lab correlates for this trial are currently pending. So one of the other things, and I know there's been a lot of discussion at this meeting about this, so I'm going to talk about this only very briefly. But some of the data that's been presented on this pH-like signature actually came out of samples on this trial. And so I think getting to the point that was made yesterday, as there's decreased funding, I think it's really, really important to still find ways to be able to collect samples and be able to bank them, because that ultimately is the way we're really going to be able to move things forward. And so, children with ALL, as we've discussed, really have an extremely poor clinical outcome when they have this pH-like gene signature. And so the COG developed this clinically adaptable screening assay to identify pH-like ALL. And when Harvey and Willman looked at the young adult population, really were able to show that this incidence, as Deepa was discussing a little bit ago, was quite high. So it's about 20 to 25% in this young adult population. And this correlates with both event-free and overall survival. And as mentioned, many of these patients now have kinase fusions that have been identified that retain these intact tyrosine kinase domains. And if you look, actually, it's interesting, and I know this was presented yesterday, but as you look from childhood to adolescent to young adults, the interesting thing is that you actually see a different pattern of fusions. And so there are different targets potentially in these patients, and there's a different incidence of these various mutations. And so, as mentioned, these mutations are potential therapeutic targets, and I think it's very, very likely that with the, Dan D'Angelo is going to be working on the upcoming new young adult trial, and so, one of the things we would really like to incorporate in that trial would be looking at this pH-like signature and trying to incorporate targeted therapy within those patient populations. And so treatment with pediatric-inspired regimens really has improved outcomes in young adults. The toxicities of such an approach in this population is feasible. I do think, it's really important to have a team of people that are comfortable with this. So it's a learning curve. So it took us a little while. When we had the first patient, I think everyone was a little panicked. But once I think everyone got used to it, it's definitely very, very feasible. And then the last thing is really there, and I think an improved understanding of this disease biology is really going to be critical in terms of building on these regimens further. And then I just would like to thank Lenny again for letting me talk today and acknowledge my team at the clinic. Thank you.